am Amriteshwari Nama. A very warm good afternoon to one and all. On behalf of the Department of Pathology, Amrita Institute of Medical Sciences, I, Dr. Jyotsna Yashodharan, am extremely delighted to welcome you all to this auspicious occasion of the International Pathology Day, IPD 2020, capturing the coronation through the lens of the pathologist. Rightly described as the bridge between science and medicine, pathology underpins every aspect of patient care, starting from diagnostic testing and collaborative treatment decisions to using cutting-edge technology, including molecular sciences and even artificial intelligence. The International Pathology Day was launched by the Royal College of Pathologists in 2014 to celebrate and acknowledge the contributions and achievements of pathology and laboratory medicine in addressing global health challenges and improving health outcomes of global communities. As the world continues to battle COVID-19 with all its arms and ammunition, we at Amrita have made a humble effort to capture the coronation through the lens of the pathologist with our scientific program. So let's all join together to celebrate our shared passion for the profession and to honor the entire laboratory team who save lives every single second. Happy International Pathology Day. Thank you.
Thank you, Dr. Jyotsna. I'm Dr. Neha.
And I'm Dr. Natasha.
And we are your MCs for the day. Without further ado, I call upon our very own Dr. Ajit Nambiar, Head of Department, AIMS Kochi, to address the gathering.
Om Amriteshwari Namaha. My humble pranams at the lotus feet of my revered Sadguru, Mata Amritandamai. These are indeed tough times, but I always believed that in adversity is the true worth of a department known. With the blessings of the Guru, I would like to congratulate each member of my team, the faculty, the postgraduates, the non-teaching staff, who have their job cut out for the next 1 year, bringing together 90 plus international national luminaries in pathology, talking to the country and the world through the Amrita pathology platforms. The 3 platforms of SAGE, that is the series of Amrita Guru e-lectures, the APNA ICP meetings, which are there from the 5th of February to the 8th, and the APUD, which is our own annual Amrita pathology update in July of 2021. Today is very special. And today it's actually, the Pathology International Day, and it's actually the icing on the cake. Any department thrives through the three rock solid pillars, the pillar of academic, clinical, and research. It is our investment in these 3 which will decide our future. The academics is the benchmark and the springboard which launches the rest. The department has strived to get this right for the undergraduates, postgraduates, fellows, and PhD students alike. The clinical lab will undergo a facelift in the coming year. Thanks to Amma and the medical director, the clinicians who make the pathology department, we at Amrita are blessed with a bucket load of clinicians. Thank you for making us grow. Research is where we have usually the weakling, and that's true of much of this country. But Corona has brought a mega push. I should compliment our principal for playing that catalyst role. As we look forward, we envisage a dedicated research lab for all our faculty to take research to the next level, and in that, propel Amrita institutions to the next orbit. My undergraduate and postgraduate students are our future. My department faculty is very passionate about them, because together we flourish. It takes two to tango. I understand an institute like Amrita, work ethics are tough, and therefore I call upon you to hold on. For the joy is when after your UG days and your PG days, that actually you understand the worth of a department and the worth of an institution. This is a difficult year. 2020 will be written in the history books as the COVID year. But in this tough situation, it is how you respond and not how you react that counts. Let me place on record Dr. Ula, who will be getting us the autopsy in COVID, the experience, which is the much awaited talk and the highlight of today's scientific program. My boss and ex-HOD, Dr. Lanjawar, will be chairing this session. Many of the youngsters and our colleagues in the department, both in the department, outside the department, will enlighten us on the various aspects of corona in the corona battlefield. Amma has specially sent us her greetings to the entire pathology family, not only here, but all over the world. Dr. Prem Nair, our medical director, has been providing us support ever since the inception of this institution for the last 22 years. Our principal has been a pillar of strength and motivation for the department. Mindray has supported us with all the logistic support for today's event. The Master of Ceremonies, Dr. Rupa, and the team has put all the sincere efforts for bringing this scientific activity today. As Amma says, and says rightly, when difficult circumstances arise in life, don't run away in fear. Rather, kindle the love within and try to overcome them. Thank you. Thank you for everyone, to everyone who has joined us today. Thank you.
Thank you, sir. Our next honored guest is Swami Poonamritanandapuri, a senior renunciate disciple of our beloved Amma, Mada Amritanandamayi Devi. Swamiji is the General Secretary of the world-renowned organization, Mada Amritanandamayi Math. For the past 30 years, he has been relentlessly engaged in noble spiritual and humanitarian activities of the Math that Amma envisioned and initiated. We heartily welcome you, Swamiji, to give the benedictory address for today's special event.
Snehalokasumohanavadanam Karunadranata Nayanam Timyam Srudajanapalana Vigram Soumyam Amritanandamayim Pranamamim. Om Amriteshwari Namaha. My humble pranams to all the dignitaries, doctors, and my dear sisters and brothers. I feel very blessed to get a chance to speak to such a dedicated group of people who are ready to serve humanity. Welcoming all of you to Amrita family. The world is passing through a very tough time. We have never experienced such a difficult situation in our life. People all over the world are suffering because of coronavirus. Amma had mentioned about this upcoming disaster long before. During her world tours and Indian tours, at every venue, Amma used to begin her speech with a strong warning. Amma said, "Children, nature is agitated because of the selfish thoughts and actions of the people. Amma sees only darkness everywhere. If people continue to live like this, there could be unimaginable reaction from the nature's side. We need to protect the harmony of nature. We have to perform more prayers and selfless actions. Plant more trees. Protect birds and animals. Otherwise, nature will try to adjust itself and we may feel it as a natural disaster. Let us think of what can we do now. Man's selfishness destroys the rhythm of nature. An invisible tiny virus could disturb the sleep of intellectual giants. It has suspended the activities of the modern world. The rationalists who used to say that they didn't want to believe in a God who is invisible. Now they have to accept the existence of a tiny invisible virus. World of science stands helpless, unable to find a solution in the age of technology. Doctors say that the solution is in remaining at home. Physical, mental, and environmental cleanliness is necessary. For physical cleanliness, take a bath in the morning. For mental purity, chant mantras. Increase the immunity of the body through prayers, meditation, and yoga. I am very sure that the medical science will find a solution with the help of dedicated scientists. But grace is also needed. Pray for the well-being of the world. Try to do whatever is possible with the help of modern technology. Also practice chanting and meditation and acquire strength and grace. And you will see crises turn into blessings. May this experience become a training to lead the world towards goodness. Thank you so much. Namah Shivaya.
Thank you, Swamiji, for your encouraging words. Next, I call upon the chief guest of the day, our dear Principal and Professor of Department of Rheumatology, AIMS Kochi, Dr. Vishal Marwa, to speak a few words.
Om Amriteshwaraya Namaha. Humble salutations at the lotus feet of our Sadguru, Mata Amritanandamayi Devi. Good morning, ladies and gentlemen. It is my proud privilege to speak to you today on the occasion of International Pathology Day. On behalf of our Medical Director, Dr. Prem Nair, I welcome each one of you for linking with us today. The subject of pathology is very vast and has multiple subspecializations. We at the Amrita Institute of Medical Sciences, Kochi, are proud to have a very dynamic department headed by Dr. Ajit Nambiar. He has a very capable team and are doing many programs like the SAGE series on a regular basis. They have also done very well in research and have a name for themselves in this country. I wish all fraternity of pathology the very best in their endeavors. They have been at the front line in the COVID-19 pandemic. They have donned more than their classical role and have done clinical duties as have been necessitated in the pandemic with full energy and enthusiasm. I wish the pathology team of AIMS the very best in their efforts and pray to Amma to bless the proceedings. Let not the pandemic dampen our spirits. To end, I quote Amma's words, "Be like the honeybee who gathers only nectar wherever it goes. Seek the goodness that is found in everyone." Jai Hind.
Thank you, sir. Now we have a special message from Dr. Chandrababu KK, Professor and Head of Orthopedics, AIMS Kochi.
A very good evening to all of you, my dear friends. I would like to thank Professor Ajit Nambiar and his team for giving me this privilege to be a part of the celebration of International Pathology Day. To me, right from my undergraduate days, pathology is an interesting and exciting subject. And I can remember a number of situations where for us clinical diagnosis was not possible and the pathologists came for our rescue. Our teachers used to tell us, if you have good knowledge of anatomy and pathology, you will mature into a very good doctor. Throughout my life as an orthopedic surgeon, CPC meetings were really an exciting experience because this is where we discuss and narrow down our diagnosis and reach the final diagnosis. What I have seen over the years, the advances in immunohistochemistry that has sharpened the diagnostic accuracy in difficult problems. We know the future of all specialties in medicine is technology driven now. The specialties are getting divided into subspecialties and microspecialties. And our pathology department in Amrita is not an exception. And I wish all the best for this meeting. Thank you.
Thank you, sir. I now call upon Dr. Sudhindran S., Professor, Department of Gastrointestinal Surgery and Liver Transplantation, to deliver the felicitation.
Hi, can you hear me? Should I start the video?
Yes, sir. Please, sir.
Video, I can't start the video. The video is blocked, I think. Shall I? Hello?
Yes, sir.
Can see me?
Yes,
Yeah.
sir, your video is seen, sir, now.
Okay, I can't see me. All right. Okay, sure. Okay, thank you very much indeed. Thank you, Ajit. Thank you, Malini, Rupa, and rest of the pathology team. I think being normal in COVID times is an extremely trying liability. Yet, we have managed to fight this battle hard and travel this long journey slowly but steadily. Now, pathology is in many ways the main workmate of GI surgery. But then I would go a little bit further and say pathology is actually the soulmate of GI surgery, because 70% of our work encompasses malignancies. Histopathology forms the soul of the basis of all these surgical decisions. So literally, pathology and gastrosurgery is bonded right at the cellular level. Their help in our department at Amrita has never been found wanting. Be it be by perhaps submitting minuscule amount of tissue, small bits of biopsy, and saying that we want the truth and nothing but the absolute truth. Or perhaps gifting them with frozen section in the middle of the night and telling them we want the answer right away. And I can say that all these times they have been extremely helpful, and thank you very much indeed for that. Our pathology department has been not only leaders of academics in Amrita, but have been equally good at not losing any opportunity to learn new things. I guess this particular conference is a typical example. It is a lovely, educational, and I hope probably a family affair as well. Amrita Institute of Medical Science is proud that such diligent, creative, department guides us in these difficult times. Let me give you, from my part, a standing ovation in favor of Department of Pathology. Thank you.
Thank you, sir. Before we move on to the scientific program, I request Dr. Rupa Paulos, Professor, Department of Pathology, AIMS Kochi, to deliver the vote of thanks.
Thank you, Neha. Let me begin by thanking God for this day and thanking Amma for all the blessings that has helped us to put this event together. We're really glad that we can join our pathology fraternity both in India and across the globe to mark this day. And today is extra special to us because this is the first time that we are conducting such an event as this on International Pathology Day. At the outset, I would like to thank our medical director, Dr. Prem Nair, for giving us the permission and also all the support to conduct this event. And a very special thank you to our principal, who is also the chief guest of this event. So thank you for your encouragement and for being with us during this time. Our sincere thanks to Swamiji for all the blessings and for the benedictory address, and also for that encouraging words, and also a mission for us to look forward to in the days to come. Thank you, Swamiji. I would like to thank Sudhirendran sir. We work together very closely in pathology with our GI, with our clinical fraternity in the institution, and we really appreciate your time with us, especially taking time out of surgery to be with us on our special day, and thank you for your felicitation. Thank you. We have received lots of messages from the luminaries in the state, and we thank each one of you for all the appreciations which we will show during the program. I'm sure all of you are looking forward to the scientific feast that is there before us. At the outset, I would like to express our sincere thanks to Dr. Ulla Mahadeva, who at a very short notice agreed to be our keynote speaker. Our thanks goes beyond Dr. Ulla to Prof. Lucas, who is one of the leading people in the world in this area. And we thank Prof. Lucas for having allowed us to borrow his prodigy for this event. We have none other than our stalwart in the country, Dr. Lanjivas sir, to chair this session. Thank you, sir. We are honored to have you here with us. I also wish to express my gratitude to Dr. Anil, microbiology, Dr. Mithun, rheumatology, Dr. Geetanjali, clinical psychology, and to Dr. Karthika, our very own faculty, who will add another dimension to our understanding in this COVID pandemic. I wish to express my appreciation to Mindray, Shama, Nikhil, and all the others in her team for conducting this program so efficiently and for all the efficient services that we have received in the past few days from you. Thank you. This event, such an event like this, could not have come together if not for the active participation of our department, the Department of Pathology, which is headed by Dr. Ajit Nambiar, who really was the driving force behind this. Thank you. But at this point, I must say that I was fortunate to work with a fantastic core team: Dr. Jyotsna, Dr. Monica, Dr. Neha, Dr. Susan, Dr. Natasha, Dr. Kirtana. All of you were not just fantastic, but more than that, infectiously enthusiastic. Thank you. I wish to thank our principal's office for all the help in disseminating the information regarding the virtual poster, the quiz competitions, and for any SOSs, they were there for us. Thank you very much. A very special mention to the judges also of these competitions. But last but not least, I wish to thank each and every one of you for being here to mark this International Pathology Day. So without any further delay, let us sit back and go through a mesmerizing ride of the coronation. Thank you all for being here.
Thank you, ma'am. A gentle reminder, a feedback form will be given at the end of the program. So please fill in your correct details so that the certificate of participation can be sent to you after the program.
Everyone, fasten your seatbelts as we are now about to venture into the glaze and maze of our pathology world through our scientific programs.
We are privileged today to have in our midst Dr. Ulla Mahadeva. Dr. Ulla Mahadeva is a renowned pathologist who developed interest in infectious disease pathology under Professor Sebastian Lucas, who is a pioneer in the field of HIV/AIDS and autopsy study. She is now leading the National Infectious Disease Histopathological Services in London. She will be enlightening us on autopsy pathology in COVID-19. I also welcome Dr. D.N. Lajeva, ex-head and professor of pathology at Grant Medical College and JJ Hospital, Mumbai. He is currently the professor and head of Department of Pathology at Adani Medical College, Gujarat. Sir was the past president of the Indian Association of Pathologists and Microbiologists. Sir has held many high offices during his illustrious career. He is the doyen of HIV autopsy pathology, with over 100 publications to his credit. We are privileged to have you, sir, to introduce our chief speaker for the day.
Good evening, everyone. I would like to welcome speaker and you all on behalf of myself and the organizers of this session.
Thank you. Thank you so much, Ulla, for this.
Thank you.
Thank you, madam and sir, for the emphatic discussion on the role of postmortem in emerging infectious diseases. Next, we have Dr. Karthika KV, Assistant Professor, Pathology, AIMS, Kochi, who will now activate our RBCs with a session on hematological abnormalities in COVID-19.
A very warm good afternoon to everyone who has joined this online platform and a very happy International Pathology Day to all my colleagues. Today, I will be speaking on the hematological abnormalities in COVID-19. Since December of last year, 2019, when COVID struck Wuhan, China, and it was reported to the WHO as an unknown cause of pneumonia, we have been faced with a pandemic of huge magnitude, which we have never faced. And here we stand today with a death toll of around 1.27 million worldwide, out of which in India, we have around 128,000 deaths as of today. So just to start, I thank Dr. Ulla for having described the structure of coronavirus and having covered most parts of my talk. And so I think I'll just go through this superficially. So COVID-19 is a virus belonging to the Coronaviridae family. And this small fellow is an RNA virus with a nucleocapsid protein and a lipid envelope. And this lipid envelope has a lot of embedded proteins which are responsible for the entry of the virus into the cell. The most important protein among this is the spike protein, which gives the corona the typical corona kind of a crown kind of an appearance. Now, this spike protein is trimeric and it has to be cleaved so that it can enter into the cell. Now, this cleaving happens through a molecule present in our own body known as TMP-RSS2. This is just to give an idea of the clinical presentation of the disease. The major problem with COVID-19 has been the protein manifestations of the disease, ranging from completely asymptomatic cases to critical cases. In asymptomatic cases, the challenges which we face is with the risk of transmission, whereas in the severe and critical disease, we are worried about the risk of fatality. So as a pathologist, every pathologist has a profound interest in knowing the pathogenesis of a disease and also share the pathogenesis with our colleagues so that there is a filling of the gap between the pathogenesis and the clinical management of the disease. So COVID-19 is basically an ongoing vicious cycle of a cytokine storm and a thromboinflammation, which culminates in the main culprit in the disease, that is PIC. PIC is the abbreviation for the pulmonary intravascular coagulation that has been classically described in COVID-19 ARDS. So what happens is, as Dr. Ulla had beautifully described, this SARS-CoV virus, with the help of its proteins, binds to the ACE2 molecule on the surface of cells present in the lungs, that is the type 2 pneumocytes, the proximal tubular cells of the kidney, the transitional epithelium of the bladder, the intestinal epithelial cells, and also the endothelial cells. And it stimulates all the inflammatory cells, and these inflammatory cells in turn release a lot of cytokines, leading to a cytokine storm. Now, the main mystery of COVID-19 was how come the infiltrate is paucicellular, whereas the cytokine storm is of such high magnitude. Now, the present evidence suggests that this primary cytokine storm is followed by a second wave of a secondary cytokine storm, which is responsible for the very large magnitude of cytokine storm which we see in relation to the pauci-inflammatory infiltrate in the affected tissues. Now, these cytokines are responsible for almost all the manifestations of the disease, and that is why we see a hyperinflammatory state in COVID-19. The clinical manifestations may be due to the hypercoagulability or the endotheliopathy. Both results in hypoxia, which presents as a respiratory failure in these patients, and also the activation of the vascular endothelium along with the hypercoagulopathy results in both macrothrombosis and microthrombosis. So this picture again shows the basic pathophysiology of the cytokine storm in COVID-19. So you can see here that the virus has attached itself to the ACE2 enzyme on the surface of the type 2 alveolar epithelial cell, and through this it is phagocytosed into the cell. Once within the cell, the ACE enzymatic function falls, and therefore the angiotensin 2 rises. It is known that the level of angiotensin 2 is markedly elevated in these patients. Angiotensin 2 has a pro-inflammatory action. It can cause direct cell apoptosis. It can also cause cytokine release. And the virus itself also stimulates the entire spectrum of inflammatory cells, starting from NK cells, CD8 cells, Th17 cells, Th1, Th2, and the macrophages. Now, once inflammatory cells are stimulated, they have their own array of cytokines to release, and each cytokine contributes to the manifestations of the disease. Usually in viral infections, this cytokine storm is regulated and controlled by a feedback, whereas in COVID-19 somehow this cytokine storm continues unabated and gives rise to a secondary cytokine storm. And these cytokines are responsible for the mass-like picture, macrophage activation syndrome-like picture, and each of these cytokines contribute to the different clinical manifestations of this disease. The other aspect of COVID-19 infection is thromboinflammation. Now, this thromboinflammation was previously hypothesized due to the proximity of the endothelial cells to the type 2 alveolar cells. But now it is found that this thromboinflammation is multifaceted in pathophysiology. What happens is the endothelial cells are damaged directly by the entry of these viral particles because, as already described, the endothelial cells have a lot of ACE2 on their surface, and the direct entry of the virus creates an endothelial injury. Furthermore, the cytokines that are released, the neutrophil extracellular traps, all these mediators injure the endothelium. Injury of the endothelium results in endothelial activation and microthrombi formation. So this is a picture showing electron microscopy of an endothelial cell loaded with virions, and the histopathology showing a neutrophilic infiltrate in the endothelial cells, classically described as the endothelitis. Both these processes, that is the cytokine storm and the thromboinflammation, culminates in PIC. PIC finally results in the intrapulmonary activation of the coagulation cascade, resulting in the intrapulmonary thrombosis and microhemorrhages. The subtle difference between the ARDS of classical pneumonia and the ARDS of COVID is that it is relatively pauci-inflammatory compared to ARDS of a typical pneumonia, and there is more of a thrombotic inflammation in the form of fibrin deposition, microthrombi, and microhemorrhages rather than inflammation. Coming to the topic proper, the laboratory abnormalities in COVID-19 actually reflects this ongoing systemic inflammation due to the cytokine storm, the resulting cell damage and increase in the cell damage markers, and also indicators of hypercoagulability. So in the complete blood count, the classically described finding is that of lymphopenia. This lymphopenia characteristically coincides with the onset of the cytokine storm, and the nadir is described at day 7 after the onset of symptoms. The mechanism may be due to the direct viral lysis through ACE2, which is present on the surface of lymphocytes, and the different cytokines which are released promote lymphocyte apoptosis. These cytokines also cause atrophy of lymphoid organs, as Dr. Ulla had shown in her PPT. And it also may be as a result of the lactic acidosis seen in these patients. That is because lactic acidosis or any kind of acidosis is toxic to lymphocytes. The other CBC abnormalities which can be seen are neutrophilia, eosinopenia, mild thrombocytopenia, and thrombocytosis. Now, thrombocytopenia is usually seen more commonly in a sepsis-associated DIC, whereas in COVID patients, the platelet counts are relatively well maintained, and in fact, some patients present with thrombocytosis. And also, unlike other viral infections, where reactive lymphocytes are commonly seen in the peripheral smear, not much of reactive lymphocytes are seen in COVID patients. There are studies which have reported that leukocytosis, lymphopenia, and thrombocytopenia are associated with greater severity and fatality of the disease. As far as inflammatory markers are concerned, ESR is classically elevated, but most studies have focused on CRP, LDH, and procalcitonin, and these very well correlate with the length of hospitalization of patients and also the severity of the disease. Now, several ratios have come into use since the onset of COVID-19. It has been found that a decreased lymphocyte white blood cell ratio reflects severe disease and fatal outcomes. This indirectly reflects the lymphopenia and the leukocytosis. Another ratio which is used in COVID-19 is a high platelet to lymphocyte ratio. This indicates platelet activation as a result of the cytokine storm. Now, platelet activation, we all know, causes thrombotic complications, which are likely to prolong the hospitalization of a patient. Also, contrary to non-survivors, surviving patients demonstrated a nadir of the lymphocyte count on day 7 and then a subsequent restoration with improvement of the disease. Therefore, we need to have a serial assessment of the lymphocyte count dynamics to predict the patient outcome. There has been no dearth of studies as far as CBC abnormalities are concerned. Of course, most of the studies have been from China, and every possible trend in the CBC parameters have been reported. This is one study which described the trend of counts in COVID patients, and as expected, among non-surviving patients, the HP fell, the WBC count was high, there was neutrophilia and lymphopenia, there was a little bit of monocytopenia and therefore significant thrombocytopenia. Coming on to the hemostatic abnormalities in COVID-19, which have been grabbing a lot of attention. Today, I would like to remember the man, the father of modern pathology, Sir Rudolf Virchow, who described the Virchow's triad, which holds true even in the era of COVID. So COVID obeys every component of the Virchow's triad. It causes endothelial injury in the form of direct invasion, release of cytokines, intravascular catheters, complement activation. It also causes stasis by causing immobilization in hospitalized patients. And also, there is a hypercoagulable state as reflected by the TEG findings, the thromboelastogram findings. So that is why there is always an element of hypercoagulability in COVID patients. But this coagulopathy is different from DIC, and that is why it has been given a separate term, COVID-associated coagulopathy, CAC. The characteristic features of CAC are that the lung is more commonly involved. It presents with thrombosis rather than bleeding. PT-APTT prolongation is less common. Anemia hemolysis is not seen. Fibrinogen is increased rather than being decreased as in DIC. And D-dimer is usually very high in these patients. So PT-APTT and D-dimer are certain tests which need to be monitored in COVID patients. PT prolongation is usually mild, so it is better to use PT measurements rather than PT-INR measurements. APTT values did not quite correlate with the severity of the disease. However, elevated D-dimer value at admission was a predictor of both severity and mortality. Now, at admission is important because it was found that D-dimer during hospitalization did not reflect the disease process, and therefore, I would like all the clinicians to do a DIC scoring at admission in COVID patients. And also, the cutoffs for starting thromboprophylaxis have been arrived at different levels in different studies, starting from 1.5 microgram per ml to 3 microgram per ml. And they say that these cutoffs need to be validated at every center rather than using one particular study. And also the elevated D-dimer levels had a very good negative predictive value of 94% for predicting venous thromboembolism in these patients. So this is a graph showing the trend of hemostatic abnormalities in COVID patients. D-dimer was high in non-survivors. PT-APTT was more prolonged, and fibrinogen had a falling trend in non-surviving patients. At Amrita, we did a small retrospective study and we gathered the hematological parameters of around 100 positive patients. Routine parameters were collected. However, 23 patients did not have any hematological evaluations. Only 48 had D-dimer values and 39 had PT-APTT values. Most of these patients fared well as far as CBC was concerned. They had an average HB of 11.6. WBC count was around 5,000. Platelet count was around 2,24,000. Only 4% had leukopenia. This may be because most of the patients treated at Amrita were belonging to the mild or the moderate disease category, and we treated lesser of severe cases. The D-dimer ranged from 0.18 to 70 microgram per ml. 58% patients had lymphopenia, and of these, 15% had high D-dimers. 4 patients had expired, 6 had severe desaturation, and the mortality correlated very well with a high D-dimer and a high NL ratio. However, statistical significance could not be established because of the low number of cases. So these were few peripheral smear pictures we had at our department. This is a pseudopelgia huae anomaly in a neutrophil from a COVID patient. These patients have been reported to have transient abnormal myelopoiesis and showed dysbiotic changes in the neutrophils such as pseudopelgia huae, abnormally clumped chromatin, dark chromatin, ring neutrophils, hypolobation, etc. This is another dysbiotic neutrophil where the neutrophil nuclei is convoluted like an embryo, also known as the embryo cell or a covicyte. We also had a 46-year-old positive patient with mild anemia and the peripheral smear showing agglutinates, and this was signed out as autoimmune hemolytic anemia, and the DCT was positive in this patient. These patients have a very well documented risk of thrombosis, and many of the lab parameters correlate with this risk of thrombosis, such as a prolonged PT or APTT, a high WBC count, high NL ratio, and a high D-dimer level. Now, why is the lab important? It's important because most of these patients, according to the present bodies of evidence, require routine thromboprophylaxis, especially the ICU patients require routine thromboprophylaxis, and these patients need to have routine monitoring of coagulation parameters such as the platelet count, PT, APTT, D-dimer, and fibrinogen. Also, viscoelastic studies such as ROTEM and TEG have shown a persistent hypercoagulable state. However, the role of these tests in monitoring therapy response and prognosis have not been studied yet. Being a condition of immune stimulation, a lot of autoimmune tests are positive, and lupus positivity has also been reported in these patients, which can be considered to be a transient abnormality with the present body of evidence. So to summarize, the laboratory changes in COVID-19 may be due to the reduced function of the organs, such as reduced albumin, increased total bilirubin, increased AST, increased ALT, or it could be hematological, such as in thrombocytopenia, increased leukocyte count, or it could be inflammatory, such as an increased LDH, increased procalcitonin, and these reflect the cytokine storm that is going on with the disease. The challenges in COVID diagnosis and monitoring is that most of these studies are recent and therefore the results are yet to be published. Furthermore, since most of the affected patients right now belong to China, at least now, most of the studies are from China. And therefore, in today's challenging times, more than ever, the clinical laboratory needs to be patient-centered and with qualified leadership to be safe, efficient, effective, and timely. I acknowledge the contributions from Dr. Lalita Biswas from our molecular lab, Dr. Anil Kumar from microbiology, all clinical departments, Dr. Geeta Vidyadharan for giving me the data, and Dr. Meera Skaria, my PG, for helping with the data. Last but not the least, I thank my parent department, the entire Department of Pathology, for giving me this opportunity, and once again wish you all a very happy International Pathology Day. Thank you.
Thank you, ma'am, for telling us how the cytokine storm leads to a macrophage activation syndrome-like picture and thromboinflammatory process. Thank you for also elaborating on the range of CBC and hemostatic abnormalities.
Nikhil, please start the video.
Yes.
NLR is the number of neutrophils divided by that of lymphocytes. NLR can be used as a marker of subclinical inflammation. Due to the body's immune response caused by COVID-19, increased NLR value in the early stages is associated with poor prognosis. NLR has been found to be important for predicting severe illness to COVID-19 patients. A study under review by The Lancet cites NLR of greater than or equal to 4.06 and lymphocytes of less than or equal to 0.765 as predictors of severe COVID-19 cases. Another study by Italian doctors indicates the cutoff value of NLR to be 4 and that COVID-19 patients with an NLR of less than 3 will show clinical improvement. Patients with NLR over 5.92 could deteriorate to severe or critical illness and should be treated with special care soon. Mindray autohematology analyzers can automatically report NLR result in every hematology test, helping clinicians predict severe illness in COVID-19 patients and better manage medical treatment.
As Jagdish Chandra Bose stated, the true laboratory is the mind, where behind illusions we uncover the laws of truth. And how can we uncover the truth without the molecular aspects? So now I request Dr. Anil Kumar, Professor of Microbiology, AIIMS Kochi, to share with us about the molecular diagnosis and experiences at AIIMS. Over to you, sir.
A very good afternoon to everyone. Can you hear me, everyone? Is the slide visible?
Yes, sir. The slide and audio is visible.
Okay. Once again, a very good afternoon to everyone. I would like to thank Dr. Ajit and Dr. Rupa for making me part of this International Pathology Day. My greetings to everyone. It's always a privilege to be in company of pathologists. I'm a microbiologist, your next door neighbor. So let's begin discussing the diagnosis of COVID, which is mostly molecular, but some amount of rapid antigen tests and antibody assays are also involved. So why do we do a diagnosis? The mainstay of diagnosis is to early identification of the patient so that we can isolate the patient, treat the patient, reduce the mortality and morbidity, and also prevent the transmission. We should always remember this is a common cold, which is causing a lot of mortality. So we have to try to prevent such preventable mortality by identifying the patients and treating the patients who require treatment and also prevent transmission. So a word on the dynamics of the viral infection. The virus is there in the respiratory tract predominantly, and you can pick it up in the respiratory tract 1 week prior to the onset of symptoms, that is pre-symptomatic, and after the onset of symptoms, you can pick it up for 3 to 4 weeks by a real-time PCR or a nucleic acid test. The virus can also be demonstrated in the stool specimens also, and when the patient becomes symptomatic, 50% of the patients do show viral particles in their stool for 3 to 4 weeks, but the clinical significance is not yet defined. The antibodies come into the circulation after 2 weeks, 10 to 14 days, and it can be demonstrated in the serum. Having said that, it doesn't follow the routine paths of IgM coming first and IgG coming later. Most of the studies say that both of them almost come simultaneously and can be picked up together. So the various assays, like PCR or antibody assay or an antigen, is deployed according to this pathogenesis. When the viral load is high in the initial stages and the viral load goes down in the lower stages, an antibody comes up into the circulation. So what are the specimens? The best specimen or the most commonly used specimen is nasopharyngeal swab. Studies have shown that it has good sensitivity of 89%. Oropharyngeal swab has got a lesser sensitivity of 21%. Newer studies are coming up where saliva is found to be as good specimen as nasopharyngeal swab. Taking saliva makes a big difference when compared to nasopharyngeal swab, the amount of distress the patient suffers, and saliva can be collected by the patient themselves. So it's a very promising specimen which is being investigated and can come up in the future. Now, BAL is a specimen which is reserved only when you don't have a nasopharyngeal swab positive and you have a high index of suspicion of the patient is having COVID pneumonia. Then you go for a BAL. It's an invasive procedure, not routinely deployed. Feces may be tested. It can come positive in 50% cases, but clinical relevance is not defined. Blood is not a good specimen. Only 1 or 3% may come positive. There is no need for testing blood for antigens or the SARS-CoV virus RNA. You can test blood for antibodies and nothing more than that. So what is the diagnostic test based on? So either we have a direct test. A direct test means you directly identify the virus in the secretion, that's an esophageal secretion, by picking up the antigen or by picking up the genome of the virus. It could be a spike protein, envelope protein, or the nucleocapsid protein, or one of the enzymes like RDRP. The gene can be picked up by using a PCR assay, or you can pick up the antigen by doing a rapid antigen test. The indirect evidence of COVID infection would be an antibody assay in the serum, and it could be IgG, IgM. Some people have looked for IgA also, but IgG and IgM are the mainstay of antibody diagnosis. So let's discuss each test one by one. The RT-PCR is, though it's not a gold standard, but it's almost near the gold standard. The gold standard is culture. Culture cannot be done nowhere because of the safety issues. So RT-PCR is considered as the gold standard. It's one of the most costliest tests that is available. 2,100 is the rate that government has fixed. There are different RT-PCR assays, and each manufacturer comes up with its own cocktail of genes. WHO mandates that at least 2 genes should be there, and one of them should be an E gene, and another could be an RDRP gene or N2 gene or ORF1A gene. In our hospital, we use a triplex PCR where we pick up E gene, RDRP, and N2 gene, and all the 3 genes are positive in most of the cases. Turnover time is 6 to 8 hours. It's a long time for a patient to wait to get a diagnosis, because the RT-PCR can be done in batches, and each batch will come around 70 to 80 samples, and extraction is the biggest bottleneck because it takes a long time for manual extraction. Limit of detection is less than 100 copies. So this is the most sensitive test. If you want to use a test which is most sensitive, go for an RT-PCR assay. Sensitivity is 60 to 80% in nasopharyngeal swab. Specificity is almost 100%. Now, specificity can go down if your molecular biology lab is not that robust and your procedures are not robust and you get a cross-contamination. Otherwise, the primers are very specific for SARS-CoV-2 and will pick up only SARS-CoV-2 and will not cross-react with other coronaviruses. So this is a schematic diagram of RT-PCR lab. This is the extraction, the most important part, where the person has to wear full PPE and extract 80 to 100 samples together. It will take 1.5 hours. This is the biggest bottleneck. But our lab has got an automated extractor, so it cuts down the time to 10 minutes or 20 minutes for extraction for 30 samples. This is the master mix preparation, where we prepare the master mix, add the RNA, and then load it to the machine. So all these 3 steps together would take 6 to 8 hours if the extraction is manual. If the extraction is automated, it will take only 3 hours for the diagnosis of COVID using an RT-PCR assay. So having done all these tests, which one do you think would be indicative of an infectious patient? Now, RT-PCR, all the nucleic acid tests picks up bits and pieces of RNA, and because of their sensitivity, they can come positive for long periods when the patient is totally asymptomatic, recovered from the infection. So just because an RT-PCR is positive doesn't mean the patient is infectious. Only an antigen which is positive indicates infectiousness, because the viral load is very, very high for an antigen to come positive. So if RT-PCR is positive or a molecular test is positive and the patient is symptomatic, then he is infectious. Otherwise, it's very unlikely that he is infectious. Studies have shown that 8 to 10 days after developing of symptoms, the patient no longer is infectious, irrespective of what test he does. So patient may not be infectious when the patient, in spite of the fact that the patient is RT-PCR positive, but an antigen positive patient is surely an infectious patient. So antibodies come into the circulation after 10 to 14 days. After 14 days only, it's prudent to go for an antibody assay, more likely to get positive. And antibody levels are based on the the severity of the infection. In severe cases, moderate to severe cases, the antibody response is very robust. In mild asymptomatic cases, the antibody response is not robust. So you get high titers of antibody in case moderate and severe cases, while you have low titers in mild asymptomatic cases. Some people do not develop an antibody at all. They use their cell-mediated immunity to counter the virus, and they may not show any antibodies, demonstrable antibodies in the circulation. Having said that, antibody test is not used for diagnosis in India. Government does not recommend antibody test for diagnosis of infection. Lateral flow assay or the CART test was used initially, but because of false positivity and poor sensitivity, it was discontinued. It was no longer recommended. Now we have an enzyme-linked immunoassay or chemiluminescence assay, which have got very high sensitivity, very good specificity, which are now deployed in India for looking at immune response, not for diagnosis, or acting as a supplementary test for diagnosis. But it has not been approved for diagnosis as of now. ELISA and CLIA can use N protein or S protein for targets. Now each manufacturer will claim the superiority of N gene or S gene, but you have to know that antibodies against S protein is neutralizing. So when you are looking for plasma donors, you have to use an assay which uses S protein to pick up antibodies rather than N protein. And Vitros from Johnson & Johnson, Vitros from Orthoclinical have got an S protein assay. So that has been approved by FDA to look for plasma donors. A level of more than 12 in Vitros assay signifies the patient has got good amount of antibodies and can be used for plasma donation. So where do we use serological tests? It is not used for diagnosis. It's used for clearing discrepancies between RT-PCR and clinical presentation. A clinician feels he's a COVID patient, an RT-PCR persistently comes negative, then you go for an antibody assay. A clinician feels that it's a post-COVID syndrome, Kawasaki, Guillain-Barré syndrome, vasculitis, they'll never come antigen positive or RT-PCR positive. Go ahead and do an antibody assay. A radiologist feels it's a CORAD 3, 4, or 5, that is, you have ground glass opicities with pneumonia in it. He's highly suspicious of this infection, COVID infection. Go ahead and RT-PCR is negative. Go ahead and do an antibody assay to prove that it's a post-COVID syndrome. You can use antibodies to solve discrepancies between different molecular tests. Now we have three different types of molecular tests. If some discrepancy is seen, we can go ahead and do an antibody test for that. It's used for seroepidemiological studies. That is what is recommended by the government of India. To identify plasma donors, that is also recommended by government of India. I said plasma donors, you have to look for antibodies against S protein, which are neutralizing. This Cochrane review found that they compared the antigen test and the rapid RT-PCR assay. They found that antigen test is only 56% sensitive, and rapid molecular test RT-PCR was 95% sensitive. So it's a big difference between both of them. So you should always remember antigen negative, high index of suspicion, go ahead and do a RT-PCR assay. So this is a sensitivity pyramid. RT-PCR has got the highest sensitivity. Expert ID now has got little lower, TrueNat a little lower. Antigen has got the least sensitivity when it comes to testing. So the pathway for diagnosis would be, if you have an expert TrueNat or antigen negative, go ahead and do a RT-PCR assay. If you have an RT-PCR negative, go ahead and do another RT-PCR assay after 2 days, or change the sample, switch over from nasopharyngeal to BAL if it permits. So what should be the testing strategy? If you use a highly sensitive test like RT-PCR, which is very expensive, not readily available, cannot be done in large numbers, and does not have access to a large number of population, you will pick up few cases which are infectious, and most of the cases would be post-infectious because it's very sensitive. You'll pick up RNA in cases who have already recovered and not very infectious. So that's the case of a highly sensitive and very expensive test. But if you use a low sensitive, inexpensive, can be easily done, can be easily deployed in the general population. The general population has access to it. You do a large number of tests. If you do a large number of tests, most of the things that you pick up is in the infectious category, the problematic category. You prevent transmission and you pick up more cases. So this is the strategy that government of India as well as the government of Kerala is following now. Previously, we used to have predominantly of RT-PCR assays and picking up lots of cases, but now we have antigen assays, which 70% of our test is antigen, only 20 to 30% is RT-PCR. So we pick up most of the infectious cases and isolate them and prevent transmission. So this is what we have done in Amrita till now. For the last 6 months, we have been doing COVID antigen test, RT-PCR test, expert, and TrueNat is also available now. We have begun TrueNat also. 37,500 odd tests we have done. You see, we picked up almost 1,000 cases in Amrita itself, and the positivity is almost 2%, 2.5%. And 2/3 of the cases are antigen assays because it's easy and can be done in large numbers. And the test positivity as of now in our population nowadays is only 5 to 6%. 5 to 6% of the people come positive. Overall, Kerala has got a positivity of 10 to 11%. We did antibody survey, antibody serosurveillance study, IgG in healthcare workers within the month of July when we didn't have community transmission in Kerala. We didn't find anybody in our hospital who was positive. Any healthcare worker was positive. Unfortunately, we got 3 false positivity. When the prevalence is low, false positivity is high in serological test. We published this in Clinical Microbiology and Infection. We did a survey in blood donors, 0.6%. Only one donor was positive in July when the community transmission is not there. And we are using antibody as part of a study to pick up radiologically CORAD 4, CORAD 5, 2 cases we have picked up who were repeatedly antigen, RT-PCR negative. We picked up IgG antibodies, they are RT-PCR positive, RT-PCR negative. Then we have picked up multisystem inflammatory syndrome in children. 2 children were positive, one of them were RT-PCR positive, both of them were IgG positive, one was RT-PCR negative. We also use it for picking up discrepancies in antigen test. If antigen is negative, we do an IgM assay, IgM comes positive. An antigen is indeterminate, we are not able to determine, the bands are very faint, we do an IgM, we pick up it's positive, then it's most likely positive. So antibody can be deployed in such cases to solve discrepancies and come out with a cheaper alternative to diagnose COVID infection rather than using an RT-PCR assay. Thank you.
Thank you, sir, for your insight on the diagnostic armamentarium for SARS-CoV-2 with practical application.
As COVID is an enemy force, we must be prepared with our defenses. Next up, we have Dr. Mithun CB, Associate Professor of Rheumatology, AIMS Kochi, who will charge us with his topic, Immunology in COVID-19.
Hello.
Hello, sir.
Hello, can you hear me?
Yes, sir, we can hear you, sir.
Okay.
Sir, your screen is not shared.
It's showing shared. 1 second. Yes. Now it's visible. Is it visible? Hello?
No, sir. No, sir. Your screen is not visible. Please share screen.
Okay.
Yeah, now we can see.
Now you can see, no?
Yes, sir, we can see.
Okay. Good evening, all. First of all, I thank Dr. Ajit and his team members for inviting me for this talk. Here, my job is to talk on the immunology of COVID-19 infection. And in my 15 minutes talk, I will try to give a broader review of the immunopathogenesis of COVID-19 infection, and also try to shed some light on why the COVID is severe in some patients and why they are mild in most of the other patients. And also some points on the autoimmunity part in COVID-19 infection, which is a hot topic now. And there may be some overlap between the previous presentations because Dr. Karthika and Dr. Ulla has they presented some part of the immune mechanisms. And coming to the COVID-19 infection, we don't know much about the COVID-19 virus, how they act, but in general, the viruses, they are a small submicroscopic infection agent that replicate only inside the living cells of an organism. And they use the machinery of the cells to replicate, and they can easily mutate. And while replicating, they can damage the cells, host cells, and the immune response against the virus can also cause damage to the host, which is a hyperinflammation. This is common to all viruses. Coming to the specific features of COVID-19 infection, as previously told by the other speakers, SARS-CoV-2 virus enters the cell via a receptor called AC2. And once these AC2 receptors are predominantly seen in the alveolar cells in the lung, and it can be also seen in GA cells, gastrointestinal cells, also in the endothelial cells. And once inside the cell, this coronavirus replicate rapidly, resulting in COVID-19 infection. But our immune system tries to prevent this COVID-19 infection. And the immune system, they are basically divided into two. That is the innate immune system, which is the first line of defense. And whereas the second line of defense is the acquired immunity or the adaptive immunity. And the innate immunity, which is the first line of defense, is the first when the infection occurs, is activates the intracellular pattern recognition receptors. For example, it's toll-like receptors 3 and 7. It's predominantly coronavirus activates these TLR3 and 7, which in turn recognizes the pathogen-associated molecular patterns. And these TLRs, that is toll-like receptors, act as sensors, which our body senses that the pathogen entered our body. And this causes an immune response. And it recruits the innate immune cells to the site of infection. The most important immune cells in coronavirus infection and other virus infection are the NK cells and macrophages and phagocytes and dendritic cells. And when they reach the site of infection, they produce inflammatory cytokines, and phagocytes try to phagocytose of the viruses. And among the cytokines, the most important is the type 1 interferons, which includes interferon alpha, interferon beta, interferon omega. And once the innate immunity, they are not able to completely eradicate the viruses, they take the help of the adaptive immunity or acquired immunity. This is the this adaptive immunity is the second phase. And this is first phase is the innate, and followed by the adaptive immunity. In adaptive immune system is basically comprised of two cells, basically T cells and B cells. And among the T cells, there are two types: cytotoxic T cells, which directly destroys the virus infected cells, whereas the helper T cells or CD4 T cells helps B cells in producing antibodies, which will neutralize the viral antigens, that is the virus itself. And once this adaptive immune system clears the viruses, then the adaptive immune response comes down, and these B cells and T cells can turn into memory B cells and memory T cells, which in turn help our immune system to produce rapid response when they encounter the antigens for the second time. Actually, this is the basis for most of the vaccinations and also for the immunity secondary to an infection. Just producing an antibody is not enough to form an adequate antibody response. There are certain factors. It depends on certain factors. The most important is the quality of antibodies. The antibodies, if it is effective, there should be a neutralizing antibody. And we should also look for the quantity, how much antibodies are produced, and also how much they last. That is also important. Also, another important thing is the antigen stability, because most of these viruses, as I told, can mutate over time. And then these antibodies formed can be useless after some time, because the virus antigen may be changed after a few months or some few years. That makes an implication in the vaccination, because like influenza vaccination, this corona vaccination also we may have to modify after a few years, or we may have to give the vaccination every year like that. It is very unlikely that vaccination will give a lifelong immunity. And coming to the COVID-19 infection stages, as you know, the many of the patients, approximately 90% of the patients have asymptomatic or some mild to moderate infection only. Why it is happening like that? For to understand that thing, we need to know the natural history of the COVID-19 infection. As I told, the first phase, that's the stage 1, we call it the early infective phase, where the viral replication predominates. Here the symptoms, basically non-specific symptoms like mild fever, dry cough, it can be myalgia. It is basically due to the viral cytopathic effects. That is a virus causing damage to the cells, and also due to the immune response, basically mainly due to the interferon response to interferon, type 1 interferons. Once the stage 1 infection, most of the patients, it stops by this stage 1 infection, because the innate immunity with the help of adaptive immunity can most of the time eradicate virus in this stage. But in some patients, it will progress to the next stage, that is called stage 2 or pulmonary phase. Here in the early, if there is a increased viral replication, it can cause increased damage to the alveolar cells, which in turn lead to the increased immune response, because once there is a damage to the cells, there can be an increased immune response to the injury. And also due to the, if the body is not able to contain the infection, there will be an exaggerated immune response to it, which will cause a hyperinflammatory phase. This was as said by Dr. Karthika in his presentation. This hyperinflammatory phase can lead to ARDS-like picture. And here the patient becomes sick, and most of the patients will go to hospital at this stage. And usually, normally, here, once the virus is eradicated, the body will automatically stop the inflammation. There is a feedback mechanism so that the host inflammatory response will be automatically shut down. This is done by the T regulatory cells and other anti-inflammatory cytokines. But this coronavirus, in some patients, prevent this feedback mechanism. Therefore, it leads to an exaggerated inflammatory response which is uncontrolled and persists for more time. Then it goes to the stage 3. That means the hyperinflammatory phase will lead to a cytokine storm, which in turn can lead to a macrophage activation like syndrome. And macrophage activation, as you know, it is not specific for COVID-19 infection. It can be a familial macrophage. It is actually acts like a familial macrophage activation syndrome with hyperferritinemia, high inflammatory markers, cytopenias, and disseminated intravascular coagulation, etc. And the cytokine storm, as I told, it is not specific. It can be seen in other infections also. And coagulopathy, the reason for the coagulopathy is the virus can directly injure the endothelium, and in presence of a hyperinflammatory stage, this will predispose to thrombosis, and in turn it can cause intravascular coagulation in multiple sites. And also there are some studies show that there is a antiphospholipid antibody, presence of antiphospholipid antibodies in some patients, but we don't know the significance of these antibodies, whether they are transient or not. Only long-term studies can show. And the treatment, there are a lot of trials which have tried many drugs for the treatment of coronavirus infection. From these trials, they have tried antivirals and anti-inflammatory also. Theoretically, the antivirus will be effective in the early phase where the viral replication predominates, and the anti-inflammatory drugs are mainly used to fight the hyperinflammatory phase of the coronavirus infection, which is responsible for most of the morbidity and mortality. And as expected, only the steroid, that is a Dexona, has shown to reduce the mortality. Whereas the antiviral drugs, which has shown not much effect on the mortality, only the remdesivir shown some effect in reducing the hospital stay. That itself shows that the major reason for the mortality in these patients is likely to be host hyperinflammatory response or the cytokine storm. And other studies, other immunomodulatory drugs like tocilizumab has been used in cytokine, although there are not much strong evidence for the same. But in some patients, definitely it can be useful, as we see in other cases of macrophage activation, where we successfully tried tocilizumab. And as I told, like the timing of treatment also very important, considering the immunopathogenesis, because in the early phases, basically it is the viral replication. Here, the antivirals will be the most useful. And if you use the anti-inflammatory drugs as steroids in this phase, that in the early phase, there will be a uncontrolled replication of the virus. Because in the early phase, if you suppress the immunity, that means if you suppress the adaptive immunity, which will help to eradicate the virus, that will be counterproductive and cause more deleterious effects. But at the same time, in the second and third stages, where there is a less of viral replication and more of a hyperinflammatory response, immune response, there the immune response can be really useful. Therefore, the timing is very important. And some points on the autoimmunity in COVID-19. There are many studies which show that there are the autoantibodies can be positive in COVID-19 infection. Most commonly, the APL antibodies and also other antibodies like ANA and anti-SSA. But the significance of this is not yet proven. But recently, there is a large number of patients have been reported, especially children with a multi-system inflammatory syndrome. They present exactly like Kawasaki disease. Here, there may not be a direct infection or a presence of active infection. Most of these patients present later. That means once the infection subsides, then only this multi-system inflammatory syndrome occurs. And it presents like a fever and with vasculitis and a multi-system involvement. Here, classically the RT-PCR will be negative, but the antibodies will be positive. And although it is commonly seen in children, it is also described in adults. And coming to the other important question, which is why this is severe in only few patients and benign in most. And there are some studies which show that there can be it's just a hypothesis only. There can be a pre-existing immunity in some patients. And studies have also proved that in one study it proved that SARS, there is a T cell reactivity in 20 to 50% of the people with no exposure to there is no exposure to the virus previously. It can be due to a infection to a similar type of virus, previous infection to a similar type of virus, because as you know, there are 6 types of coronavirus previously we know. Among that, 4 are causing the common cold-like disease. Therefore, there may be a previous infection which may cause a cross-reactivity, which may be protecting the individual. The same like the T cell reactivity, they can produce antibodies which can cross-react with the SARS coronavirus. And the most importantly, the genetics. As you know, the most of the things are basically genetically based, because these patients which are getting severe COVID-19 infections, they are likely that they are genetically susceptible to those type of viral infections. And this has been shown in some studies, especially this is a recent article from in the NEGM. They have done a genome-wide association study in severe COVID patients. They have found a genetic susceptibility locus in chromosome 3p and 9q. And 9q is actually a gene which is for the ABO blood group. And in the further study, they showed that those with a blood group A have a severe infection, whereas blood group O has a protective effect. And another interesting study which is published in the Science, has shown that there is a deficiency in interferon proteins, because type 1 interferons, which is considered responsible for the immunity against viral infections. And these deficiencies are actually predisposing to severe COVID-19 infections. And one study by the Sang et al., they have shown that there are some inherited mutations in the interferon signal pathway, either in the TLR3 and also in the interferon receptor. They have shown there is inherited mutations which in turn cause a quantitative and qualitative reduction of interferon gamma, type 1 interferon, which basically interferon alpha and beta, which in turn predispose the patient to a severe COVID-19 infection. And in that same issue, they have published another article by which showed that there is a development of autoantibodies against which interferon, type 1 interferon, which neutralize the interferons. It is these patients develop antibodies before the COVID-19 infection, because they said that because they have collected the samples at the onset of disease, and some patients, 2 patients actually had never documented infection. They had an infection, they had an antibody without COVID-19 infection. That is an antibody against the interferon alpha and beta. These antibodies actually reduce the levels of interferons, which in turn predispose to COVID-19 infections. Why these antibodies are formed, there are some hypotheses. They show that there is basically these are cytokines. The antibodies should not produce antibodies against interferons, but in old age, due to immune senescence, our body can lose the B cell tolerance and can produce antibodies against the cytokines. This is one hypothesis they have mentioned. And coming to my last slide, and this is the $1 million question, and how long the immunity lasts from a natural infection of COVID-19? The answer is no one knows the answer, and even the presence of antibodies cannot actually assure you to protect you from a second infection, because antibodies should be neutralizing antibody. And other thing is that even if antibodies are negative, you can be still protected from COVID-19 infection due to the T cell memory, and therefore we still don't know how long immunity will last from a natural infection or vaccination. Thank you.
Thank you, sir, for explaining to us how our immune system is earnestly fighting against COVID-19.
What we achieve inwardly will change our outer reality, as stated by Plutarch. Mental health has always been important, and in these devastating times, it has a more pivotal role to play. Dr. Geetanjali Natarajan, Professor of Clinical Psychology, AIIMS Kochi, will now enlighten us on the mental health challenges in Corona times. Over to you, ma'am.
Madam, please unmute yourself.
Sorry. Am I audible now?
Yes, ma'am.
Okay.
But your share screen has stopped.
1 second. Is it fine now?
Yes, ma'am.
All right. So, good evening, everybody. I'm really happy that presentation on mental health is also included in a pathology meeting. Just emphasizing that in this Corona times, mental health challenges, and mental health especially is extremely significant. And let me quickly go to the presentation. So let's first see what are the different kind of challenges we are facing during this corona times. The first one is how it has disrupted our routine completely. It's now that we realize how, in a very mechanical manner, working days, the way we used to structure our days and go about our activities in such a clockwork kind of way. And the whole thing came to a big standstill with all the lockdown and stay at home. The next one was a big source of conflict was with people staying at home, those who were already homemakers, as well as people who just used to rush for work. Everybody is at home, including the children. And who does what? How do we share our roles? This started becoming a very big source of conflict for a lot of people during this time. Also, another important area was how good were we in our interpersonal relations. People who found themselves locked within the house, this aspect became so important, because if you have people who are supportive, helpful, and there for you, it made so much of a difference compared to even if I start speaking, it is misunderstood, or we get into fights, arguments. I feel isolated in spite of having near and dear ones around. So within our homes, the kind of relationship we had, if it was problematic, then we might as well be alone rather than with a person who is getting at our nerves. The other thing that we saw very commonly happening is mobile addiction, addiction to substances, overeating, all these behaviors which started, people started losing control over these behaviors and started becoming a source of entertainment as well as a source of handling stress. You see a lot of people engaging in stress eating, and then most of the time on the screen. Children were hooked to the screen 24 hours, and especially with all this online classes, children were bought mobile phones, whereas earlier we used to take it away from them. And coming to the fifth one, the huge uncertainty of things. So the COVID-19 pandemic itself brought in a lot of uncertainties in the sense, when am I going to get it? How about my children, my family members, my people who work with me? I would find myself constantly worrying and getting anxious about these things. Apart from that, we also see that people close to us would have got the disease. Some of them very unfortunate that they succumb to the disorder, and we even see there are a lot of death happening. So bereavement and losing near and dear ones is definitely something we all worry about. And definitely the lockdown also brought its own challenges. How long is it going to be? Some of the countries, they have the second wave of lockdown happening, and lot of changes in work with economic recession happening, lot of layoff, people lose their jobs, they come back to we have a lot of these people from Gulf and other countries who have lost their job, who are here. So how is it going to be? When am I going to get a job back? What about all the increasing loans which I need to be repaying? And also lot of questions come about whether we can actually re-establish the earlier routine. So we speak of the new normal, the whole world is changing and we are gearing up for a new normal without actually knowing what this new normal is going to be. We have glimpses of it, but we really don't know. At the same time, how am I, with all this stay at home, work from home, how am I going to re-establish my routine once we get back to our old way of working? So these are broadly some of the challenges, and what does it cause? These uncertainty, change in routine, role sharing conflicts, interpersonal problems, and a lot of these addictive behaviors, they all lead to worry and anxiety, low mood, frustration, anger, a sense of loss of interest and meaninglessness, and more addictive or compulsive behaviors, eating disturbances, insomnia. These are all the kind of stress-related problems that we encounter when the COVID challenges happen. So let's look at what can we do about it. Now, what happened during this pandemic? It brought us face to face with few hardcore realities that we do lack awareness about mental health. Not only mental health disorders, let's not go into that, but even taking care of one's own mental health. What is it that I need to be doing? The other thing that was very evident was that we haven't paid enough attention to our social relationship, connectivity with other people. And again, how aware are we about what practices we can do to take care, self-care, and take care of oneself. These were all things that became very evident that we are not really equipped with. So let's quickly see some, for all these problems, what can we do about it? What are simple skills that can be solutions? So the first one is being well aware of and learning to identify and know one's own thoughts and feelings. So a lot of times there is very less acceptance or becoming comfortable with one's own thoughts. We try to struggle with our thoughts, correct it, make it positive. But at the same time, we also struggle with a lot of unpleasant emotions, not knowing that this is a stressful time and that we are normally expected to have negative thoughts, unpleasant feelings, anxiety due to the uncertainty, low mood. These are all part of the stress that we are going through during this difficult time. So can we actually become aware and learn to be comfortable with this than trying to get rid of it or avoid it? And what we really need to be taking control of is only our actions, not our thoughts or feelings. The second one is being clearly aware of what is it that we can control. So a lot of time our energy and time and effort is spent into trying to control things which are really not under our control. For instance, we really don't need to control our thoughts and feelings. We cannot control what others do. We cannot control the past or be fully certain about the future. We cannot control what finally would happen, the result. And also this uncertainty is not something that we can control. But what we can control is our own actions, what we do in the present, can we, the kind of effort that we can put into, and also taking charge of our daily activities. A good routine, a structure, and with good balance about work and rest and recreation and spending time with our near and dear ones. A good routine can go a long way in handling stress. The other important skill that we can have is to be mindful, to be in the now or the present, being aware of what we are doing, simple things that we are doing, even our hand washing which we do, if we can do it mindfully, the daily activities like eating, taking a bath, doing an exercise, all these things can be done mindfully and learning to be in the present rather than getting caught up in our worries, fears, all these negative, pessimistic thinking. So instead of thinking or worrying about work or other things when we are in bed, or worrying about my sleep or rest when we are working, we can really focus on what we are doing at the present and be mindful. That can also be very helpful. Next one is, as I said, interpersonal relationship and being supportive, being there for the other person, not getting into fights and conflicts, can be extremely helpful during the stressful time. So empathy is a very good skill where we are able to put ourselves in the shoes of the other person and understand and accept and support the other person. Lot of times we only see our side of the story because we know what's happening with us. If we fail to be present somewhere, we know why we were late, but we are very intolerant to the other person because we are not really able to understand what's going on in the other person. But if we show patience and the willingness to understand that, we can not only help ourselves, we can help the other person and improve upon our relationship. The other, again, to maintain good relationship, one thing that can go a long way is effective communication. Can we actually learn to understand the other person? Lot of times we see people rushing to talk but not ready to listen. So can we listen more, try to understand what the person is really trying to communicate? So a lot of times we focus on the words or the content of what the other person is saying, but can we actually focus on the need that the person is trying to express rather than what they end up saying? So focusing on effective communication, if we are actually getting into fights, arguments, then it is time to think that I need to make changes in the way I communicate. And finally, a very important skill that is essential during this time is self-compassion, where we are not hard on ourselves. We are very good at being kind to others, forgiving others, helping others, but we fail to help ourselves, be compassionate to ourselves, forgive ourselves if we haven't been able to be as efficient as I was before the COVID, during this lockdown, during at a time when there is so much stress and uncertainty, lack of structure. We are bound to not be at our efficient self. And can I be compassionate towards myself? And also gratitude, where even small things that our colleague or friends or family members do for us, we need to be grateful, express it, not only in our mind, be able to thank and be grateful for their being there for us. So these, I think, are some of the skills that if we possess, we can actually go a long way towards handling this crisis in a much more pleasant and calm and peaceful manner. So controllability, knowing one's thoughts and feeling, mindfulness, empathy and communicating effectively, and self-compassion and gratitude are solutions or skills that we need to develop and possess. So with that short presentation, thank you.
Yes, ma'am. Handling stress and anxiety during these uncertain times is truly a challenge and has to be addressed with communication, compassion, and understanding. Thank you, ma'am, for your thought-provoking talk.
It's time to announce the winners for Dr. Neha. If there are any questions, you can go ahead to ask questions. Is there any problem? Hello? Hello?
Hello?
Yes.
Yeah, Shama, can you?
Yeah.
Can you hear us?
I can hear, yeah.
So can we go ahead with announcement of results?
Yes.
Yeah. So we move on to the much awaited results of the competitions held in connection with IPD 2020 aims for our undergraduates. First, the virtual poster competition for undergraduates. The first prize, cash prize of rupees 7,000, goes to Ms. Nayantara Sudesh, third year MBBS, Amrita Institute, Kochi. The second prize, cash prize of rupees 3,000, goes to Aishwarya R, 2017 batch MBBS AIMS. The first place in the quiz competition held in connection with IPD 2020 goes to Mr. Rahul Radhakrishnan, MBBS batch AIMS. Moving on to the results of the contest held in the Department of Pathology. The first prize for the pathography contest goes to Dr. Kirtana Chandran, first year PG resident, Department of Pathology. The first prize for pathomeme contest goes to Dr. Malini Ipan, Professor, Department of Pathology, Amrita. Congratulations to all the winners. Please, all attendees, please do fill the feedback form so that we can issue you the certificate through your emails. So please fill in all your details clearly and correctly. Thank you.
Thank you all for joining us in celebrating this International Pathology Day 2020. We hope to see you all soon for our next event, which will start at 7. Otherwise, we will see you hopefully next year, 2021, for the International Pathology Day. So have best wishes from all of us here. Thank you very much. At this point, I would also like to thank our telemedicine for giving us this opportunity, for giving us a room for us to conduct this. We also once again want to express our thanks to the medical administration for all the support that they have offered us to conduct this program. Thank you very much to one and all.